This is the PalliM Podcast, a production of pallium.org at the intersection of palliative and emergency medicine. I'm your host, Justin Bruton. Today on the PalliM Podcast, I'm joined by Jennifer McEntee and Daniel Markwalter. Jennifer McEntee is an associate professor in the Department of Medicine and Pediatrics and serves as a clinician educator, academic hospitalist, and palliative care and hospice provider. Dr. McEntee also serves as the Associate Program Director for the Internal Medicine Residency Program for the inpatient rotations. In addition to degrees in education and public health, she completed her residency in internal medicine and pediatrics at the University of North Carolina, Chapel Hill, and fellowship training in hospice and palliative medicine at Duke University. Dr. McEntee is extremely interested in improving medical provider-patient communication, medical provider resiliency, international health, public health, quality improvement, resident and medical student education, and in promoting competent, compassionate, patient-oriented care. Daniel Markwalter received his emergency medicine residency training at the University of North Carolina, where he served as education chief resident and completed fellowship training in palliative care. He is currently an assistant professor in the Department of Emergency Medicine and the UNC Palliative Care Program. His scholarly interests include ED-based advanced care planning, transitions to hospice from the ED, and palliative care education for emergency medicine physicians. Dr. Markwalter is also a contributor to content at pallium.org. Thank you both for joining us today.
Thanks for having us.
Thank you.
I appreciate you letting me be a guest interviewer on today's episode. Today we're talking about a subject that I think is near and dear to both emergency medicine and palliative care these days, and that's ketamine. Many of us are familiar with the use of ketamine for sedation and agitation in the emergency department, and a lot of newer protocols for analgesic dosing. There seems to be an explosion of routes of administration these days, intranasal options, looking at topical and nebulized ketamine, recent studies on the use of ketamine for depression. It really is a big ketamine world out there. So we want to pivot a little bit to the use of ketamine and the overlap between palliative care and the emergency department. There was some interest in this at the recent 2022 annual assembly. And so we're excited to have one of our experts from the University of North Carolina here, Dr. McEntee. And she was the palliative care driver behind the ketamine policy at UNC. And so we're glad to have you here. But I know in particular, you have a story that sort of sparked your interest in the subject. Would you mind sharing that with us?
Yeah, thank you so much again for having me to also help spread the word of how ketamine can really help most of our patients, or many of our patients. So this patient was a beautiful 40-year-old woman, mother of three, who was diagnosed with de novo metastatic breast cancer in 2017. And we have seen her numerous times throughout her hospitalizations. Many of those times were for pain crisis secondary to refractory pain. The most memorable one related to ketamine was she presented with 10 out of 10 refractory pain. At home, she was on methadone, 30 milligrams TID. She was also on a Dilaudid PCA, 1.5 milligrams Q15 minutes, and she was also on dexamethasone. We continued to kind of ramp that pain medicine up through her hospitalization, and we were getting nowhere. Her pain still was 10 out of 10. At that point, we decided to transfer her to the ICU because we had to, because that was the ketamine policy at UNC at that point in time. All of our patients had to be treated in the ICU. Subsequently, that is no longer the case, which I'm really excited for. We can now treat these patients on the floor. And we transitioned her we started her on a ketamine dose on, let's just say June 2nd at 0.1 mg per kg per hour. And we were able to slowly titrate that up to 0.25 mg per kg per hour over the next couple days. When I saw her 3 days later, I approached her and she told me she was in 0 out of 10 pain, which I was in utter disbelief. I told her I didn't believe her because I'd never seen her without pain, without 10 out of 10 pain. For 4.5 years, she was unable to climb a flight of stairs. She was unable to play with her kids and to do any physical activity with her kids because of the pain. And so she said, "I'll prove this to you, doc." And she stood up and danced with me in the room. And so she was really adamant that she needed to get out in a couple days because she needed to go see her daughter graduate. And we knew time was limited because of her de novo metastatic breast cancer. So we got her out of the hospital on the 5th day of ketamine. We quickly transitioned her to PO ketamine. And so she was discharged on 20 milligrams of PO ketamine TID. She was also transitioned to methadone, 40 milligrams PO TID, and a Dilaudid PCA. At that day, she was discharged. She walked into her daughter's graduation. That weekend, she played tennis, and she walked up a flight of stairs to be able to sleep with her husband. And then 7 days after discharge, she was transitioned off of her PCA just to oral Dilaudid and continued on the oral ketamine and the oral methadone. So quite a remarkable story. And when I asked her if I could share her story, she said, "Oh my gosh, please tell everyone about ketamine and please tell my story." So it was a remarkable story for all of us.
That's awesome. Really seems like one of those practice-changing cases, and something that I think we all hope with the right patient selection is something we can replicate in other patients as well. But taking a step back from that specific example to kind of the larger scope, in your mind, why should emergency medicine and palliative care physicians care about ketamine beyond its use in sedation where it was traditionally been used? And then in particular, why is the palliative care world really excited about it right now?
Well, I think two major things about ketamine that I want to share is, number one, it's relatively safe medicine. It's probably a safer medicine than any of the medicines we prescribe. It has a safety profile. Let me just say, since it was FDA approved in 1970, there was only one lethal case that has ever been administered or has been associated with ketamine. And that was, unfortunately, the Elijah McClain incident in 2019 in Aurora, Colorado, where he got a 7 probably mg per kg dose of ketamine times 2. And we give, just as a reminder, of what sub-anesthetic dosing is. So analgesic dosing for ketamine is 0.1 mg per kg. And I know we'll talk a little bit more about that, but that is a significant difference between 7 mg per kg and 0.1 mg per kg. So it's a relatively safe medicine. And then number two, we don't have anything in our arsenals for opioid refractory pain, other than sometimes sedation and other pain adjuvants. And so what do we do when we get to the point where we have these patients, and many of us see these patients in the emergency room and internal medicine as a hospitalist, I see these patients, and in palliative care, I see these patients who have life-limiting illness and have refractory pain to opioids. And I think ketamine can be a really good adjuvant therapy.
Excellent. So let's dig into the details a little bit. So we're all on the same page. Can you provide us an overview of some of the ketamine pharmacology and how it works to provide analgesia?
Yeah. So ketamine acts on one of my new favorite receptors, the NMDA receptor. And so at its resting state, magnesium blocks the NMDA receptor. And when the NMDA receptor gets activated, it releases sodium and calcium into the neuronal channel. And as you remember, going back to your first, second years of medical school, sodium and calcium are very important ions in the pain pathway. The NMDA receptor mirrors the opioid receptors in the neuronal membrane, and calcium activates, if I can remember this right, protein kinase C, which diffuses to the neuronal membrane and then causes hyperalgesia and opioid tolerance. And so the hope is that if we can decrease the calcium influx, decrease protein kinase C, we can actually decrease opioid tolerance, which we think maybe resets our opioid receptors. The other important aspect that many of us kind of forget about is that it also decreases interleukin-6, which is a really important cytokine that causes inflammation. And so if we can also decrease inflammation by decreasing interleukin-6, we could also potentially decrease pain. So I think ketamine hits different receptors and different mechanisms of actions for its pain. Lastly, I'll comment that it also hits the muscarinic dopamine, norepinephrine, and serotonin receptors, which I'm sure, Daniel, you can talk a lot more about that and how it relates to as an antidepressant. And I think many of our patients who have been in pain and have severe pain probably have a component of depression, anxiety, and existential suffering, which I think ketamine may help in regards to the kind of euphoria that you get with ketamine. And it can help with the depression and the anxiety. So I think that should not be forgotten when we talk about the other mechanisms of actions for ketamine.
Yeah, I think you're absolutely right. And from an anecdotal standpoint, from patients I've used analgesic ketamine on, frequently it's with conditions with significant overlap with psychiatric disease, or even in the setting of chronic life-limiting illness such as cancer or significant overlying components of anxiety or depression. And, I agree with your assessment that there's likely benefit from the other receptor actions as well. And so thinking about the different routes of administration, you talked a little bit about the IV infusion in the case that you gave us, converting over to oral ketamine. Talk to us a little bit about how it can be administered and what you know about its use in these different forms. And myself and Justin can chime in a little bit about some of the other options that we see in the ED, intranasal use, or recent trials on nebulized ketamine and even topical or mucosal ketamine.
That's awesome. Great. So I'll talk a little bit about the formulation and administration that we use for subanesthetic or subanesthetic dosing for pain or analgesic pain or analgesic administration for ketamine. So it's simply just the IV solution that's actually administered in all these different routes. And so it's the IV solution through the IV, through the subcutaneous route. If you give ketamine IV or subcutaneous, in the IV, it's active within seconds, we think. Subcutaneously, it maybe takes 15 to 20 minutes. The oral bioavailability of ketamine is tricky. We think it's probably anywhere between 1 to 17% of the bioavailability for oral ketamine. The important thing to remember is that it's metabolized by C3A4 to norketamine, and norketamine is bioavailable. It is bioactive in our system. And so we think norketamine does play a significant role in the oral version of ketamine in its actions. And so I think the administration is nice with ketamine because it can be administered IV, subcutaneous. There's topical preparations. You talked about intranasal. It can also be supplied through a suppository rectally. So I think there's lots of different variations on how we can administer ketamine if you can find the pharmacy to compound it or to actually provide the patient with the medication.
Yeah, and frequently I've seen that be a barrier to some patients in the palliative care world when we're talking about outpatient use, with finding the appropriate pharmacy for the preparation, certainly. In the emergency department, I think probably outside of IV dosing or intramuscular dosing in the setting of agitation, I think intranasal use would be the one that ED providers are next most familiar with, often at dosing around probably like 1 mg per kg. Of interest, there was a trial published in the Annals of Emergency Medicine in December of last year that looked at 3 different dosing regimens of nebulized ketamine for pain in the ER. They looked at 0.75 mg per kg, 1 mg per kg, and 1.5 mg per kg in nebulized forms, and saw a reduction in pain scores for all 3 dosing regimens of a similar magnitude. And then there are options available for topical ketamine, looking at use in complex regional pain syndromes or neuropathic pain, reducing allodynia, and then even use for kind of oral solution for mucositis pain. I'm going to flip it over to Justin. I know he's had some experience with this as well. Justin, what's your experience been?
Well, it's interesting. Actually, recently I've had several trauma patients who have been hemodynamically unstable and we're needing to start chest tubes and do other things. So that's been really helpful to have something in the arsenal that you can give when you really don't want to give them opiates and you're trying to resuscitate them. Kind of very different from the palliative care world. Certainly burns. We have a burn center, so many times I've used it for burns as an adjuvant, along with when we're having escalating doses of opiates. And then in the palliative care, in addition, I haven't actually used it as much in palliative care in the IV form. I've had some experience with that with needing with patients. Our current protocols have it limited to our inpatient pain service, so we use it a lot in the ED. But our inpatient pain service has access to that. Where I've personally used it some in palliative medicine, fortunately, we do have local compounding pharmacies. It's actually for refractory neuropathic pain, so topical preparations. I found to be helpful, and I've had patients really get some benefit from that.
Yeah, excellent.
Yeah, that's great.
And so I think we got a couple examples just then of maybe some patient populations where this could be helpful, but let's maybe be a little more specific so that our listeners can get a sense of who they might identify as great candidates for ketamine. So, the 2 broad categories might be patients requiring palliation in the ED for some acute incident or maybe acute on chronic pain. And then there's sort of the broader palliative care population. And so in your opinion, Dr. McEntee, what patients should we be thinking of and considering for analgesic ketamine?
So I think as you, Daniel, and Justin commented, really refractory neuropathic pain is something that we don't have a lot of tools in our arsenal for. And so I think that is something that we should think about ketamine. So refractory neuropathic pain, again, pain that's refractory to opioids, we are just not touching it with opioids and we're escalating rather quickly. I think the other patient population are that we need to talk about is our patients with sickle cell disease. There have been many case reports about the benefit of using ketamine in our patients with sickle cell disease by decreasing their opioid tolerance and maybe resetting their opioid receptors and decreasing the amount of opioids that these patients experience throughout their lifetime. And I think that is something that I would love to see us start using more at UNC and at other tertiary quaternary care academic centers. And then lastly, patients who cannot tolerate the side effects of opioids. So if they have severe constipation, if they have severe nausea, vomiting, and sedation, or like you said, Justin, are hypotensive and their clinical status is tenuous, ketamine generally doesn't have a hypotensive side effect, right? The side effects of ketamine generally are the opposite, will cause hypertension or tachycardia. And so I think probably those 4 patient populations, again, refractory neuropathic pain, opioid refractory pain, patients with sickle cell disease, and then patients who are really having a hard time tolerating the side effects of opioids.
Excellent. And I think Justin mentioned a few populations that we may think of specifically in the ED. And yes, there's some overlap, those who are on chronic opioids, and we may be looking for opioid sparing options or ways to dose reduce. But in the acute setting, poorly controlled pain in the setting of burns is very common. Trauma is a great one, especially for a short acting agent where you need to do some procedures such as chest tubes, even conditions leading to severe respiratory distress in which you can provide some analgesia. But in the ED, if it's consistent with patients' goals of care, it can also allow you a chance to then provide maybe some dissociative dose ketamine to then provide some respiratory support. And so it's a very flexible agent in that regard in the ED.
And can I add something, Daniel?
Yeah.
I think as I think about this more, I think another patient population that would benefit is those patients who have somatic pain, so physical nociceptive neuropathic pain, and also have this component of existential suffering, anxiety, depression, where we know ketamine has an important role, specifically with depression. I think if all 3 of 4 or 5 of those things coexist in the same patient, which happens in many of our palliative care patients, specifically our young palliative care patients, I think ketamine may also play an important role there.
For sure. Excellent. So we've identified different routes of administration, some patients that may benefit from ketamine, but we also need to be thinking about who it's not appropriate for. So Dr. McEntee, tell us a little bit about the contraindications to ketamine use, and are there any studies or things we need to look at before trying ketamine in a patient?
Yeah, so I'll talk about the second first, the latter. There are no great randomized control studies in regards to ketamine. There are no randomized control trials in regards to sickle cell patients, which I would really love, with sickle cell disease, which I would really love to get off the ground and use have a multi-center study for that specific patient population. And the caveat of everything that I'm about to say is that all of the side effects and contraindications regarding ketamine have been all based on anesthetic dosing, which again is 10 times higher than the dosing we use for analgesic dosing. So the side effects that we see predominantly for ketamine, again, are the psychomimetic effects. So those emergence phenomenon of having some hallucinations, auditory visual hallucinations, some cognitive effects that all go away once ketamine is stopped. The cardiovascular side effects we also see are like increased heart rate, increased systolic blood pressure. From a GI perspective, we can see nausea, we can see anorexia, and some hypersalivation. There are relatively no contraindications to ketamine. We at UNC have a policy that says there's a grade B, so moderate contraindication regarding psychosis. So we generally, who are patients who are psychotic, we don't give ketamine to because that will, again, increase the risk of ongoing psychosis and pregnancy. The other relative kind of moderate contraindications are severe cardiovascular disease, increased intracranial pressure, increased intraocular pressure, cirrhosis, and moderate liver disease. Again, those contraindications are all based on 10 times dosing at the anesthetic dosing versus the 1/10 of that dosing, which is analgesic dosing.
Excellent. I think many listeners will be interested in how the policy developed here at UNC. At many places, the anesthesia pain service is sort of in charge or has traditionally been in charge of ketamine infusions. Certainly in the ED, we are equipped and comfortable and capable of using ketamine in the ED. But once a patient maybe is admitted, how does the palliative care service take over that? Or specifically at UNC, how did that policy come about?
Sure.
And to give the palliative care team and the consult service the opportunity to manage that medication?
Yeah, so that's all really relatively exciting new news. When I first joined faculty back to UNC in 2016, it was a really barren landscape of ketamine. In fact, we lost a patient early on that probably would have benefited from ketamine and may have prevented her death, which was then highlighted to me as the need that I need to do something about ketamine at UNC. And so I did some research and found as a new faculty member that there's another faculty member who actually did residency with Dr. Andrew LeBlanc, who's in anesthesia, who was help leading and spearheading the ketamine policy at UNC. And so then the two of us joined forces and did grand rounds once we got the ketamine policy approved for internal medicine grand rounds and anesthesia grand rounds, and continued to kind of do ongoing work. And we continued to push for palliative care providers to be able to write for ketamine. And Dr. LeBlanc really wanted the ketamine policy just to be successful at UNC. And so we were very conservative at the very beginning and only letting anesthesia pain write for ketamine. And when we saw the success and how safe this medicine really is, we continued to train our palliative care faculty and fellows and advanced practice providers on the use of ketamine and how to write for ketamine and look at the order set and reevaluate the order set. And in January of 2022, for 6 years after I joined faculty, we were able to finally have our palliative care providers write for ketamine, which is a huge step in the landscape of ketamine at UNC. It really broadens our scope as providers, as well as providing, I would argue, better patient care at UNC.
Yeah, that's great. And so I think it might be helpful to even hear a little bit about what the policy at UNC looks like so that others can think about maybe an appropriate dosing regimen or how to create a protocol at their institution. So based on what's been developed at UNC, what are your recommendations for dosing and initiation?
Yeah, so at UNC, because of the conservative nature of our policy, we don't do any bolus dosing or a trial dose of ketamine. So for a patient who comes in and needs ketamine for refractory pain, and we want to use it in the IV form, we generally start patients off on a 0.1 mg per kg per hour infusion of ketamine. And we will go to a max dose of 0.5 mg per kg per hour. In the literature, you'll see a max dose of 1 mg per kg per hour for, again, at sub-anesthetic dosing, at analgesia dosing. But we maxed ours out at 0.5, which again is very conservative. We realize that, but we wanted to prove that this is a safe, kind of a successful medication. We've had success with that max dosing. And we will titrate that up maybe every 8 to 12 hours. So maybe twice a day, and double it to like 0.1, and we'll only go by 0.05 microgram per kg per hour increments. And we'll use it over 5 to 7 days is kind of the length of the IV infusion that we'll use. At that point, we think we'll see the benefit and hopefully the opioid receptors have reset. If we decide to stop the infusion, palliative care will recommend maybe transitioning to oral ketamine if we've seen some benefit. Oral ketamine, generally I would start off, despite what your dose was from an IV infusion, 10 to 25 milligrams Q8 hours. And you can titrate that up over every 48 hours by about 25%. And you can titrate that up to the max dose, which is 200 milligrams Q6 hours, which I have never seen, or 0.5 mg per kg, which is would be your max dose. The oral ketamine is tricky because we don't think there's any randomized control trials for large randomized controlled trials for IV ketamine. There's hardly anything for oral ketamine. And so I would say probably the length of duration for oral ketamine would be maybe 1 month, 3 to 4 weeks. At that point, the major side effect that you're looking out for oral ketamine is ulcerative cystitis. So maybe getting weekly urine dipsticks just to make sure that you're not developing ulcerative cystitis is something that I would be concerned about from a long-term side effect of ketamine. This is what we see in patients who have substance use disorder or abuse ketamine on the streets. So generally, again, start at 0.1 and titrate up to 0.5 mg per kg over 5 to 7 days for IV ketamine infusion. And for PO, I would generally start 10 to 25 milligrams Q8 hours and increase by 25% every 48 hours, if that makes sense.
It absolutely does. And, you call that conservative, but I think for ED physicians who have been using bolus dosing for pain in the ER, it's going to sound very familiar. So the ER here, typical dosing will be 0.1 to 0.3 mg per kg if you're just going to do a bolus for pain, having done that for chest tubes or orthopedic injuries. No, I actually think that aligns really nicely probably with what a lot of people's experience is. And so certainly then hearing about how that, gets translated into an infusion and then kind of what that transition to oral ketamine is like, that, as you said, is kind of a data-free zone. There's much to be desired with understanding exactly probably what the best dosing regimen is, but it sounds like you've had success with that.
We've had success with numerous patients in regards to oral ketamine. And some even patients where IV ketamine didn't work, oral ketamine has worked. I can't explain that, but that has been our patient's experience. And then I think the other thing that I should probably mention is because of the hypersalivation that you can get with IV ketamine, generally we provide, write for an order for glycopyrrolate, just PRN for the side effect prophylaxis. And then if they do have hallucinations and they can tolerate the hallucination and they're not super bothered by it, sometimes we just let that continue to happen. For example, my patient that I mentioned at the very beginning of this podcast, she was definitely having some auditory hallucinations where she was hearing that the nurses were talking about sex on the beach, and she said that was fine. She really appreciated. She knew that it wasn't real, and she kind of appreciated having that experience. And so if it does bother the patients, but we think we're having benefit from the ketamine, we will try benzodiazepines, low-dose benzodiazepines or low-dose Haldol to kind of help with that known side effect of the medication.
Yeah. I think you touched on this briefly before, but just to kind of, drive home the point, what sort of ongoing monitoring, or you mentioned side effects already, but what sort of ongoing monitoring do you need for these folks? Whether, are they always on a monitor? Are you getting daily lab draws? What sort of monitoring do these folks get?
Yeah, so that is, again, our policy at UNC highlights that they want a baseline EKG. There's no indication for that, but that is what our policy says. A baseline EKG, a basic metabolic panel, making sure they're not pregnant, so a urine pregnancy test, and then ongoing monitoring while they're on ketamine because of the tachycardia that it can definitely cause. And so those patients generally are on a telemetry monitoring. Mm-hmm. They don't have to be in a telemetry monitored unit, just a unit that they can have a remote tele is fine. And then as we start the infusion, we get vital signs more frequently, like Q4 hours for the first 24 hours. But then after that, if their vital signs are stable, we just continue to have regular vital sign checks. The other thing that I didn't mention before is that as we titrate up the ketamine, we generally decrease the opioids by half. So as we start ketamine, we cut their opioids in half, and then we continue. If we're seeing good pain relief, we will continue to kind of cut the opioids and decrease the opioids as we're seeing increased benefit from the ketamine.
Yeah, and I think that's a really important point to drive home, that for many of these patients, it does not only necessitate a reduction in their opioid dosing, but while they're on the infusion, but hopefully for maintenance afterwards. And so, the question from there is sort of, you said, 5 to 7 days is kind of typical max length. What endpoint are you looking for therapy? You started somebody on an infusion. What's sort of your endpoint where you say, all right, I think we're where we need to be, let's work on getting off of the infusion?
Definitely what I look for is decrease in their pain, whatever that is, a pain where they can function, hopefully, or at least function better than they were functioning before. And if we reach that pain, then if we reach that threshold, I keep them on the infusion for maybe 24, 48 hours to kind of make sure we maintain that effect. And then we'll slowly transition them off and onto oral ketamine if we've seen the effect. And if we don't see the effect within 3 to 5 days, then ketamine may not be the drug of choice for them. It may not be a drug that works for them. Mm-hmm. And then we can just stop the ketamine infusion and continue the opioids and think about novel therapies or interventional procedures. So I think we're looking for the effect that we want on their pain and on their daily life and their function.
Yeah.
And if we can get that, then we can stop the ketamine infusion, transition to oral ketamine, and continue their opioids, and hopefully follow up with their palliative care provider as an outpatient so we can continue to titrate down their opioids.
Perfect. And I think for our listeners, it's really interesting because, we have some, palliative care providers, maybe some who are more in the ED world, some who are straddling both. And obviously the protocol that you've described is for an inpatient infusion, but maybe in the future we'll have enough data to back up or tell us more about converting people from maybe they got some IV ketamine in the ER and getting them on oral ketamine and getting them discharged, maybe some options for even a more abbreviated regimen. So I think you mentioned this before, but just to sort of drive home the point and get people thinking about it, it's not like there are ketamine pills sitting around. So when you're getting somebody on oral ketamine, how do you prescribe it?
I think the best piece of advice is check with your pharmacy to make sure they have it before you even think about prescribing it. Because if they don't have it and if they can't get it, it's a moot point. It is relatively cheap. It's a World Health Organization essential drug. So it's a WHO list of essential drugs. And so at UNC, for example, I think it's $17 to get it filled for a 2-week supply. And the important thing to remember about oral ketamine is that it only will last for 2 weeks. After 2 weeks, it's no longer in an acceptable form. I don't know if it biodegrades at that point in time. It's no longer effective or safe to administer. So after 2 weeks, we can only use the oral ketamine for 2 weeks. So after 2 weeks, we have to discard it. And so you have to, number one, have a pharmacy who can prescribe or who can fill it, have an insurance or a patient be able to afford the copay or afford the $17, and then be able to have a provider who's going to be willing to kind of prescribe it ongoingly. And so generally the dose that I would start at, again, is it's just the IV form in the liquid solution that people drink. And you can find compounding pharmacy that will make it into a pill in certain areas of North Carolina, at least. And we generally start off at 10 to 25 milligrams Q8 hours is generally the starting dose. If they've gotten an IV dose in the emergency room and they tolerated that well and you want to transition to oral ketamine, you could probably do 20, 25 Q8 hours and be safe. And then have an ongoing provider continue to monitor them. Does that answer your question?
Yeah, absolutely. And some of this is obviously going to be dependent on, as you said, the local pharmacies. And so that's the importance of checking with pharmacies. But also when it comes to follow-up, that's going to depend on the structure and network and what your local resources are. And so give us a sense of who's following up these patients for the palliative care team at UNC.
Yeah, so many of times our UNC palliative care outpatient providers will follow these patients up, whether it is a palliative care provider that's embedded in our cancer clinic with UNC or embedded in our internal medicine clinic. And so if the patient doesn't have cancer, the patient can go to our palliative care provider in our general internal medicine clinic. And so generally they're palliative care providers who are following them up. If the patient's going home on hospice will also follow them up and hopefully continue to provide ketamine if it's on their formulary. And then I think my hope is that as we get more and more and more of our residents and internal medicine physicians comfortable with this drug, again, I would like to highlight that it's safer than many of the drugs that we prescribe them, that they will be able to and feel comfortable helping meet this need for our patients if this is shown to be really beneficial.
Yeah. And I'm really glad you brought up the piece about hospice as well, because for many hospice agencies, this is on their formulary, and many inpatient hospice units will and do use ketamine as an adjunct or as an independent analgesic outside of opioids. And so knowing that, especially from an ED standpoint, if you have a patient who is dying and you're having trouble with pain control, but you feel like they are stable enough and it's in line with their goals to get them to an inpatient hospice unit, you may actually find inpatient hospice units who are okay with you starting them on ketamine and getting them to the inpatient unit where they will continue the ketamine. And so
good point.
It's not just for folks who were thinking about plugging into a clinic scenario. It may be someone you see in the ED who ultimately will go to hospice.
Right.
Much about ketamine is either a data-free zone or a data-limited zone, whether it's oral ketamine, topical, nebulized ketamine. We're just looking for more data. We aren't great at identifying, which patients will benefit exactly, what the optimal protocols are. Where do you see ketamine going in the future, and what are your hopes for research and its use?
Yeah, so I really would love to partner with anybody who's out there who wants to do a multi-centered trial in regards to ketamine with our patients with sickle cell disease, as well as with our palliative care patients who have opioid refractory pain. I think that's where the data needs to come from. It's really hard, and why I'm focusing on patients with sickle cell disease is because it's really hard to get patients in our palliative care population to conduct research. It's really hard for me to deny a medicine that I think could help them if they're randomized to a medicine that may not be helpful to them as like a placebo in regards to opioid refractory pain, I would give them ketamine if that was my patient. And so it's really hard for me to deny them ketamine if they only have days to live and they're in refractory pain. It's really hard to conduct research on that patient population. And it's really hard for them to come in for research. And so that's why I really would like to focus on the patients with sickle cell disease, because I think that is a much more readily studied patient population and could really benefit from the use of ketamine in their lives. Mm-hmm. I think the hope is that we can, when we can't get randomized controlled trials, you have to go to the Cochrane Review. The Cochrane Review said there's not enough evidence. And then where do you go? You go to the guidelines. And I think this is where palliative care needs to kind of step up to the plate in my mind and really start developing palliative care guidelines in the use of ketamine, around the use of ketamine. Anesthesia, as we were writing our policy for UNC, anesthesia had just come out with their own guidelines about the use of ketamine, oral and IV, for chronic and acute pain. And so I think we, as maybe departments of medicine, departments of emergency medicine, palliative care, anesthesia, need to come together to form kind of universal guidelines if we can't get randomized controlled trials started and initiated. So that's what I'd really love to see, kind of these uniform guidelines for this patient population specifically. And then again, like I said, I would love to partner with anybody who's interested in our patients with sickle cell disease, because I think they would really benefit. And then I'd love to see kind of how ketamine can also be used for patients with existential suffering or this deep sense of anxiety and depression around their pain and around their suffering, because I think there is maybe potential use for ketamine in that specific patient population, because I think that is why some of my patients have had benefit from ketamine. And so I think there's a lot of hope around ketamine. I am not naive enough to think that it's going to be the end-all be-all drug for everybody. It definitely isn't, and it's definitely not for many patients. But if it does work for some patients, it's really nice to find out those patients that it works for, and to give them some pain-free days or some painless days, for sure.
Yeah. And kind of to bring it home, is there anything we haven't touched on that you think our listeners should hear?
I think the goal of all physicians, specifically palliative care physicians, is to make every day as good as we can for our patients and to help them live as well as they can. And I think if ketamine can help that and can provide well-being for our patients and help them live the best life that they can live with whatever time they may have left, I think it needs to be in our arsenal. And so I think in our arsenal of tools to kind of help treat these patients. And I'd love to be an advocate for that and also help other institutions, other providers in regards to the use of ketamine. And I think we just need to think outside the box at times for many of our patients when the traditional therapies don't work. And I think this may be one of those times that we can think outside the box.
Absolutely. And we're real excited to see kind of what the future of ketamine is.
Yeah, I hope to be on this podcast again in a year or so that we can recap what the advances of ketamine have been.
I love it. Thank you very much.
Thanks so much for having me.
Yep, you bet.
Thank you so much, Dr. McEntee. That was extremely informative. And as somebody who appreciates having this tool in my arsenal in practice, you've given me some more ideas about how it can be utilized. And Dr. Markwalter, thank you for being our guest interviewer for this episode, and also for your contributions to our content on palliative.org. Thank you both.
Happy to be a part of it.
For more information on current topics in the fields of palliative and emergency medicine, please visit palliative.org.